Great. Wonderful. Well, thank you everyone for for coming and joining us today for this webinar, United Against TB. Damagi is very excited to be spotlighting our global partner efforts. And my name is Kelly Collins. I am the Vice President of Digital Adherence here at Damagi. And so very excited to introduce our speakers today. But very quickly, just running you through what we will be discussing on our webinar. The plan today will be for me to introduce our speakers, and I'll give a quick introduction to Damagi if you are unaware of what Damagi does globally. And then we will get into our partner spotlights on Eswatini and Health Through Walls, speaking about engagements in Eswatini, Mozambique, and Haiti. So very excited to be presenting this to you today. And this is our first webinar that we've hosted with our partners. And so this is a really exciting day for our team to be highlighting contexts where we work globally. So thank you for joining us. I'm very thrilled to announce and introduce to you Shadaibu Messina and Ivan Calder, who are here as our speakers today. Shadaibu is the PMDT coordinator at the National TB Control Program in Eswatini, which is formerly the Kingdom of Swaziland, if you are unaware of the country's name change. Shadaibu today is speaking on behalf of Sifewe Ningwena, who is the acting TB Control Program Manager with the Ministry of Health in Eswatini. Sifewe was unable to present today, so Shadaibu has graciously agreed to present on her behalf. And she is the programmatic management, or she has been working in programmatic management of drug-resistant TB at the Eswatini NTP since joining in 2021. So thank you so much, Shadaibu, for being here today. Our second presenter is Ivan Calder. Ivan brings nearly 20 years of experience in healthcare and justice administration to Health Through Walls, which is an organization that provides healthcare services to incarcerated persons across the 16 countries. Ivan's career began in nursing, focusing on patient education, and has evolved into leadership roles in treatment programs and correctional facilities globally. As the CEO of Health Through Walls, Ivan works internationally, emphasizing the value of every individual within correctional systems. And Ivan chairs the International Corrections and Prisons Association Health Network, which offers valuable insights into global challenges in these settings. So welcome to both Shadaibu and Ivan. We are really honored to have you here with us today. And thank you so much for being willing to present on your organization's behalf. Great. Well, I'm going to jump into a very quick introduction of Damagi before passing off this webinar to our partners. For those of you who are unfamiliar with Damagi, we are a 20-year-old technology company, which was founded out of MIT and Harvard in 2002. We're a social enterprise that has built some of the most widely scaled digital health tools globally. You might be familiar with our ComCare platform, which empowers frontline community health workers with digital tools for client and patient support. Today, I'm also going to highlight Sugared Here, which is Damagi's digital adherence and treatment support platform. Sugared Here is a technology spinout that I co-founded out of the University of California, San Diego in 2014. And Sugared Here was acquired by Damagi in 2022. So now we are working under the Damagi umbrella and very glad to be here. Sugared Here, the technology was originally designed to support treatment adherence to complex tuberculosis regimens, though our platform has evolved over time to support really any use case that requires high fidelity to pharmaceutical or behavioral intervention. This is just a quick look at the global regions where Sugared Here is being used. For context today, we do support over 360 state and local TB jurisdictions in the US, as well as a number of global settings in Europe, Africa, and Asia. Today, we're highlighting two very unique settings in Eswatini and Haiti, where the Health Through Walls and the NTP in Eswatini have contextualized technology rollouts to their local communities. So while these technology deployments have not been without challenges that you'll hear about today, really my team at Damagi has been consistently impressed at the innovation in trainings and protocol development and patient support that these organizations have used to navigate the rollout of these technologies. So we're really excited to be learning from these organizations consistently, and I'm happy to be hosting this webinar for them to share their experiences with you today. We also will have some time for Q&A at the end, so please hold your questions as you get into, as you're learning from our presenters today. Please hold your questions, and we will open up the floor for Q&A at the end. So Sajabu, I'm going to go ahead and hand this off to you. I'm going to go on mute, and I will advance your slides. But thank you very much for joining, and so I'm going to pass it off to you. Thanks, Sajabu.
Kelly, am I audible enough?
You are. We can hear you very well.
Thank you, Kelly. Thank you for the introduction. I would say good evening because in my side it's already evening. Colleagues, I'll be presenting behalf of our program manager, Sipiwe Ngwenya. We'll be giving an overview of Eswatini. Can we have a next slide, please? This is the presentation outline, is our country context. Next slide, please. This is the background of Eswatini. Like we have seen Eswatini in the world map, it's just like a dot on the left side. There is the geographical picture of Eswatini. Apparently, Eswatini has a population of 1,200 population, and we are still one of the countries with the high TB burden countries, with an incidence of 325 per 100,000 population. Our reef-resistant MDR incident is 19 per 100,000, and our TB co-infection rate is still high, 72%, according to the WHO 2023 report. We're still having our diagnostic network, which are having 35 gene experts in 38 sites. We've got 2 culture labs, one at Mbabane, the other one at Eswatini, and we've got 1 DST lab, which is situated at Mbabane, the national, the NTRL, and the LPA, which with the TRL is housing the DST, LPA, and sequencing. And we have got 151 TPBMUs, basic management units, and 14 DR sites, which are distributed evenly all the 4 regions of Eswatini. Next slide, please. This is our case notification from 2020 to 2023. Like WHO has alluded, we have seen case notification decline from 2016 to 2023. For the DS side in 2020, we're able to notify 3,806, and the previous year, 2023, we have notified 2,239, of which we have seen a lot of decline. Same applies on the drug resistant sites. We see where we are not notifying cases very well. From 2016, it's 384, up last year it's 119. So we are not able to notify our cases correctly due to the case detection that's as a continent, as a country, we're experiencing. Next slide, please. Okay. While we are notifying our cases, we are involving the community. In the community, we've got community cadres, which are supported by Global Fund, which are champions that's distributed all the 4 regions of Eswatini. Their target, it's according to our national strategic plan, is to notify around 25% per annum. From 2019, they were able to bring up cases 13%. Able to notify 33%, last year 34%. So the community cadres, they are doing a very great job because they are based in the community. All they do, they go to the facility, they notify the index case, then they will follow to the index case to their respective home. Then they will screen those people around around that area, and will take samples. And most of our TB cases, they're coming from the community. Next slide, please. Next slide, please. Like I've stated in my introduction, that we are still one of the 30 countries with a high TB HIV burden. Our positivity rate is 65%. What's good about it, we have got an 98 ART coverage, and the WHO estimated HIV positivity rate is 57%. So all our clients know their status. Almost 99% of them, they know their status, and they are on ARTs. And most of them, they are suppressed because they're being followed promptly by our healthcare workers in the facility. Next slide, please. These are the outcome. I'll start with the drug susceptible. From 2018, our treatment success rate were 86. We were almost there, 90% from our WHO target. And unfortunately, 2021, we regressed to 81 up until 79. But the good part of it, last year, we were able to pick up, we are in 83%. And our death rate, it's a little bit high. We know that our death rate was supposed to be, we're supposed to have less than 10%, but right now we are above 10%. On my right, there's the treatment success rate according to region. Manzini is leading with, or Shiselweni is leading with 86%, followed by Manzini 85, Lubombo 80, and Hoho 78. Even our death rate, the highest death rate we received from Hoho region, followed by Manzini and Lubombo in Shiselweni, they are at 8%. By the way, our death mortality rate, it's 11%. Let's move to the next slide. On the other side, yes, our treatment success rate, it's 85%. It's 85%. From less than 80% in 2018. However, in 2021, we experienced a regress again, where we were at 75%. But this year we were able to pick up. Our treatment success rate is 84%. On my right side, there's the a picture of Eswatini with the treatment success rate per region, where Shiselweni is 97%, followed by Hoho 96%, Lubombo 85%, then Manzini 76%. Next slide, please. These are the success from the NTCP. And the TB program has implemented various programs. We have already introduced 10 color gene experts and TB sequencing. As we know from our 2017, we've got our 2017 survey, we detected that we have got this mutation that was preventing our gene experts to detect TB cases. So with the introduction of 10 color, it helps that we maximize our case finding, because we're able to pick up we're able to pick up those cases that the 6 color wasn't able to pick up cases. And also the targeting sequencing that is done at NTRL and Babane, it's very, very helpful, because even if the client was missed on the gene expect, the targeted sequencing will able to pick most of our resistant clients during those case finding processes that is being done at the lab. Also, as we know, it's very difficult to diagnose children. Even you can do gastric lavage, most of them, they will come positive, negative due to the bacilli. But we have introduced, with the help of Baylor, we have introduced a stool sample test, where our children will be diagnosed TB using a stool. Then on the TB side, we were able as a country to migrate from injectables to oral or all orals. As we're speaking, all our clients are on oral regimen. Moreover, as a country, we were able, last year, February, we were able to introduce the BPAL and BPAL treatment that our clients are able to take 6 months and 9 months treatment on their TB treatment with less side effects and shortening time. We have got this community screening. I've already added in other previous slide that we've got the community cadres who are distributed evenly in the 4 region of Eswatini, that they go to the homes, go to the community, they do the screening for those index cases that were identified at the hospital. Lastly, we have comprehensive patient support, which have done a great work in improving the treatment support in the DM site. Next slide, please. This is the comprehensive support package. It's entitled both NDS and DR. Basically, patients are diagnosed TB. They need support. Like a number of researchers have shown that while the clients being on treatment, they need to be monitored. So we have a direct observed therapy that has been shown to work for TB patients due to the nature of the disease. Although there is no empower the patients to be responsible for their own health. Then we have got the patients are for both DS, that is drug susceptible, and DR, that is drug resistant. Both patients are being supported. They've got a treatment supporter. We prefer a community one because that one, the community one does not have a biasness. However, clients prefer a family one because once you use a community treatment supporter, the client will feel like they will be disclosing their illness to a community. So in the DS side, the treatment supporter, it's a family and they don't get any stipend. On the drug resistant side, a patient are allowed to have a treatment supporter, which is a family. However, we do still prefer the community one. But because the treatment supporter, they are receiving 500 emalangeni as a stipend, so the client prefer to choose a relative one, so that with this money they were able to help them while improving their lives. Moreover, we have introduced VOT, VDOT, where the client is being observed while taking medication with the use of a smartphone. Next slide, please. Okay, these slides just show the difference between the PDOT and the VDOT. VDOT is when the client is using the cell phone while recording or using a cell phone without a treatment supporter. Both clients, they will receive their transport allowance, 300 emalangeni every month when they're in intensive phase, 150 emalangeni when they're in continuation phase. They both receive the nutritional support, which amounts to 700 emalangeni in the various doses. The VDOT will get both. They will got the support, the food nutritional support for both a patient on VDOT and PDOT. However, the client on VDOT, he will use the smartphone with data, and he will record him or herself while all the duration of his or her treatment. The patient on PDOT, he will have a treatment supporter that will monitor him or her, and the treatment supporter will get the monthly stipend of 500 emalangeni. Next slide, please. This is just a snapshot that we are using, or what is happening when the client is on video supported therapy. The client will show the medication to the healthcare worker, all the medication, including if the client is on ART, if the client is on the NCT like diabetes, hypertension, the client will show the medication to a healthcare worker. There's a Sorry, someone is knocking at my door. Anyway, it's just passed. There's a picture of a smartphone where by then we're using short A, but we are now going to use the image. So the client will just press the start, will record the video. Then after he or she finished recording the video, when the client say press stop, the video will be uploaded to the server. On the other hand, the healthcare worker will review the video and will make comments, whatever he or she saw. Sometimes the client will make a long video. Sometimes the client will record a short video. Some of the videos, they will not be clear. So the healthcare worker on the other side will write a note and call the client, kindly do ABC if ever there was hindrances. If the client has reported any side effect or any complaint, the healthcare worker hence will call the client again and give the client the assurance. If the client needs to come back to the hospital, the healthcare worker will give the instruction so that the client can be monitored monitored. Next slide, please. Okay, this is the inception of VOT. Basically, it was implemented by MSF in 2020. We know 2020 there was every country was hit by COVID. It was piloted by MSF with the local health worker with the use of show adhere right now will be the image. Then following documents were developed. We have the standard, the SOP. We have got a cell phone contract, the instruction video, how the client should record the video, and the smartphone were provided by MSF. And this smartphone when handed over after the client was finished treatment. The cell phone came with a preloaded data, and the show adhere application was installed in the cell phone. Okay, next slide, please. Then the following documents were developed to assist the implementation of VST. We have got eligibility criteria. It's a long document. I just took a snapshot that will catch your attention. All clients are eligible for, all DL-type clients are eligible for VST, even in children. The healthcare worker will teach the guardian how to record the video while giving the child the medication. Patients who reside in the MTN area network, in Eswatini, our network that is dominating, it's MTN. So all those clients who have got a good network coverage in MTN, they are eligible. We have got a problem with those clients who are residing around along the peripheral. So those have got that challenge of because there are these competing networks from our neighboring countries. Our clients who we want to be monitored promptly on VOT, all clients on BPAL, modified shorter regimen, longer regimen, XDR, and individual regimen. Even psychiatric patients are included. But you, as a healthcare worker, you need to do a mental health status evaluation so that you can see the client will able to follow the instruction correctly. Then the exclusion criteria: clients who are INH mono, who are in RZE, they won't be initiated in VOT, and unless the client who opt out, because are those clients who don't want to record videos themselves. Then the contract, there is a contract where the client is expected to sign. Before the client signs the contract, the healthcare worker is expected to read word by word, sentence by sentence to the client, and even give the client the contract to go at home to read. And in the contract, it states clearly what is expected of the client while he's on VOT. Next slide, please. When supervision of VOT, we have got an on-site on-site, regional, and central. The on-site, the client is being supervised by a healthcare worker. Our healthcare worker include nurses, screening officers, and adherents. All this and screening help, all these cadres were called on a training, and we even do a supervision, on-site supervision, training them how to observe the video and how to comment on the platform. Then for regional, we have got regional doctors, facility managers, and regional coordinators, the one who oversee what's happening, is it happening correctly. Then the central supervision, where the national staff, that's the PMDT team, we have got a PMDT team, we've got a psychosocial, we've got on the PMDT team, we've got a psychosocial, we've got a PMDT TA, and myself, who usually once a week will just supervise, will view the videos, view the facilities, and as a national team, we are not allowed to comment. We just call this facility and tell them whatsoever we've seen and how best they can improve on supervising the client. Next slide, please. Lessons, challenges, and lessons learned. I'll start with the challenges. We have got a competition between VOT and the treatment supporter stipend. As you were, that will count, most our clients opt to use the treatment supporter versus the VOT. Same as some clients refuse when they are given cell phones, they refuse to bring them back. Regardless, we've read and given them on the cell phone contract, which states that the client is supposed to bring back after treatment completion. Some of the cell phones, they come back with the broken screens because, you know, anyone is, we usually drop our phones, then they will be damaged. Some of the cell phones get lost, and lastly, some of our clients are experiencing poor network, especially those who are peripheral, even though they're eligible. So they will opt not to be initiated in VOT. Then the lesson learned. Our patient should be, we have learned that we should give the good advantages of VOT versus the treatment community versus the treatment supporter, because here the client is able to be in contact with the patient daily, and the client is able to honor his or her own treatment, because right now if I'm on VOT, I'm able to know at 7 o'clock I need to take my medication. Patient is given more information. Patient should be given more information, and they should understand the importance of VOT. Cell phone should be put screen cards and put to avoid them from being damaged, and patients were able to change. Patients were able to be, the patient will able to be in charge of their treatment when they are on VOT. There is no one who will follow me, go and take your medication. I know it's 7 o'clock, I'm taking my medication. They are able to be in contact with the healthcare worker daily for any other complaints. Whenever I'm having the problem, I know I'll report on the video, then I know the healthcare worker will respond by calling. Then we will communicate with their way forward regarding that problem. Next slide, please. The way forward. As the program will add another digital adherence that is a smart spill boxes to both DS and DR, but we'll start with the 14 DR sites, then we will move to the other 151 PMUs. Smart pill boxes will be enrolled to DR patients and those who are not eligible to VOT, and we even said we will even enroll some of the DS clients in the smart pill boxes. Also, DSTP clients, yes, I've already said that. Also, DSTP clients who are in the 14 on the 14 facilities that are providing DR will benefit from this innovation. Procurement of pill boxes was included in the Global Fund grant. Yes, when we are still waiting for their response, if they are about to respond at any time. Next slide, please. I would like, as an NTP, as a PMDT coordinator on behalf of the program manager, I would like to pass our acknowledgements to the NTCP staff, the NTRL staff, even the healthcare workers from the TP, BMUs, and DRTP sites, WHO, implementing partners that are supporting TP, that is Georgetown University, Aspire Project, Baylor Clinic, ICAP, and MSF. And lastly, we would like to acknowledge Global Fund who support us financially. Ladies and gentlemen, colleagues, this marks the end of my presentation. Back to you, Kelly. Thank you.
Thank you so much, Shajibu. This is really wonderful. And yeah, I'm going to stop my share, and Ivan, you can go ahead and share. But while you're doing that, I just wanted to acknowledge the wonderful treatment support ecosystem that you have in Eswatini. I think hearing about all of the different possibilities for clients to be supported during TB treatment, I think is really wonderful. And we've learned a lot from your program when trying to think through how do we support holistically a client as they're moving through TB treatment, not monitor them per se, but actually provide that additional support and provide multiple modalities for that. So very wonderful to hear you present on this, Shajibu. And we do have a few questions, but we're going to hold them to the end in the interest of time. Great. Ivan, I'm going to pass it off to you.
Thank you very much, Kelly, and thank you for that wonderful presentation, Shajibu. As per the introduction, my name is Ivan Calder. I'm the Chief Executive Officer for a non-government organisation called Health Through Wars. A big acknowledgement to our president and co-founder, Dr. John May, who set up Health Through Wars 20 years ago. You'll see from my first slide, we're going to jump to the Caribbean. So we'll talk about TB detection and treatment in prisons and the use of technology in Haiti. And if there's time, we'll also jump to Mozambique. I'll specifically focus on VOT and the use of applications for the collection of healthcare data. And if we have time, I'll jump into artificial intelligence. An acknowledgement of the Stop TB partnership as well, who have given us funding in order to undertake work in Haiti and in Mozambique. So who are we? Health Through Wars, non-government organisation running for 20 years, and we assist justice and health systems in prisons specifically to develop their healthcare service delivery. So we work in capacity building, we work in healthcare delivery, although our role is more enablement. We work to advocate with governments for change, low resource countries, medium income countries, people in places of detention don't benefit from a lot of anything. We've also undertaken work on infrastructure upgrades and food security so that people get fed and people have suitable accommodation. Technology has a big role in this ballpark, and that's where I would like to talk to you in a moment about the work that we've done with Surety Dimagi in making the patient experience in prisons better, the healthcare staff experience more fruitful, and disease detection of the highest impact. This pictorial representation demonstrates areas where we currently have impact, and as you can see, we're Africa and Caribbean centric, although our reach is growing. Our ambition is not world domination. Our ambition is to support the 12 million people in places of detention. Yes, that's right, 12 million as it stands. That's the prisoner population and the systems that operate around them. So why is it important to look at disease detection in prisons? Well, as many of you will know, prisons are a vector for disease spread. You can see in the pop-up in the bottom left-hand corner, the incident rate ratio for prisons to the general population. In America, it's about 4 times as many people in prison per one person in the community. In South America, it goes up to about 27 times. So if you get your public health response right in prisons, you get your public health response right in the general community. And when you times that out by 12 million people in close proximity to one another, the impacts become tangible and palpable, and particularly where TB is concerned, closed environments, massive overcrowding, disease spread is inevitable and rife. So we were lucky enough to be funded by TB Reach for Wave 6, the Wave 6 project. And this was for video observed therapy in the Haitian prisons. In Haiti, there are nearly 12,000 people in prison across 17 prison locations. In some locations, the overcrowding runs to about 400%, which is staggering. The number of healthcare staff is tiny. The reach across the prison system of healthcare staff is limited. And so there are many overcrowded facilities where there's little or no access to healthcare, and where the only healthcare advocacy is through the prison system correctional staff, who through this project have demonstrated themselves to be an absolute unwavering and necessary ally. As many of you will know and have seen from the terrible news flowing out of Haiti at the moment, this is not new news. Prisons are in lockdown, prison escapes are happening, the country's in crisis, 5.5, 6 million people are in food insecurity, gangs have got controls of the ports, the airports, the seaports. It's a very difficult operating environment to navigate for anybody, and it's a very difficult operating environment to tolerate if you have little or no agency over your life and your health because you're incarcerated. And it's worth noting that in the Haitian prisons, about 90% of individuals have not been sentenced. So there could be a presumption for innocence there for many. And for those who have, often the length of sentence is disproportionate to the crime because the justice system is inadequate to deal with the processing and review of people in places of detention. So what did we do? We identified 5 prisons where there was no provision for TB therapy, and 3 control sites where we applied directly observed therapy, so healthcare staff observing people take TB medication to look at their compliance. In the 5 locations, the intervention locations, we provided the correctional officers with handheld video tablets so that they were able to record and observe individuals taking their medication. We were then able to upload that data and confirm adherence. And in the absence that there was no electricity, no internet connection, which is often and frequent in the countries in which we work, then we would take self-report. In terms of the evaluation of the program, as you can see, we collected demographic data through surveys, both from the DOT and the VOT cohorts, and the patients and staff participated. And there's a reference there to parts of the evidence base. So what did we find? Well, the technology enabled by Sure Adhere was absolutely fantastic, and no, I don't get a kickback for saying that. It's just a statement of fact. In our initial tranche of work, we had 67 patients, as you can see, who were enrolled. Adherence was nearly 90%, and when adherence confirmed by a correctional officer occurred, it was 100%, and we had no treatment failures. Challenges not dissimilar to those articulated by the Eswatini team, but maintaining the technology so that it was usable and could report back for our functioning was a big one, very much linked to internet connection, electricity, but also, as I've already said, the civil unrest was significant in limiting the numbers and the reach of the technology in the first instance. And what our conclusion was, as you can see, is that VOT gave us another very strong tool in our toolkit to ensure that we have a mechanism to tackle and treat tuberculosis in the Haitian prisons. That's not the conclusion, because we've carried on post this project with VOT scale up using Dimargi's sure adherence technology. We've expanded to 6 intervention locations. We've currently got 231 individuals who are active and with whom we're using DOT. And in total, over the past 5 or 6 years, we've had a total patient cohort of 685. So the outcome, well, what have we learned? This is a piece of technology that we trust in, and it's a team that administrate it that we've built a trusted relationship with. The lessons learnt, equipment can be faulty, networks can be inconsistent, you need a manual workaround on a paper-based system on occasion, and phone lines often go down. But despite this, and I'm just going to have to move the banner so I can read my own writing, no treatment failures have been reported to date, and I think that's absolutely remarkable given the operating environment that we're in. Just give me a second. My screen, there we go. I'm going to bunny hop now very quickly over to Mozambique, which, as many of you will know, is right next door to Eswatini. We were funded for a Wave 10 project by TB Reach to work with the Mozambican prison system. What you've got here is a lovely picture of the team in action doing a screening in the maximum security prison in Maputo, and this was July of last year. I'm not going to run through all of the project parameters because of time. What I will do is quickly take us through the patient flow. 3 prisons, assessment and screening, and this is where technology comes in, for multiple health conditions. And you'll see there everything from TB down to malnutrition and mental illness. And then the process supported by peer educators, and then a pathway into the community. For this project, we worked with Dimargi to develop a data capture solution that could track the patient from point of entry into the prison system to point of exit from the prison system and everything in between. And so we developed what we called the Health Matters app. It collects about 180 different data points through a workflow, and it enables you to go back in and enter data and update the workflow. So you get everything from a patient name, age, demographic data through to diagnostic data, which in the world of TB and TB management and TB preventative therapy is absolutely imperative. So at any given time, with this device, handheld tablet, administered by a clinician or allied health worker, that speak across a network to one another in real time if you have the connectivity, we were able to understand the exact position for a patient in the prison system. This is significant for 2 reasons. One is low resource countries prisons in low resource countries often get overlooked because it's thought, well, we can't afford the technology, or the technology has no place in our environment. And this is absolute proof to the contrary. The second is Mozambique and the Mozambican prison system are a fearless prison system and to be commended. They were very honest about their current state of record keeping, which on a good day was paper-based, on a bad day was not at all. And when you're imagining that level of record keeping for patients who are potentially who potentially have TB, and when you think about disease spread and management, you've lost the fight before you started. So we were delighted to work with Dimargi. It took about, if I total the time solidly, about 2 weeks of solid work to build the skeleton of the application. It took about another 100 minor modifications in order to get the workflow precisely right and to iron out the kinks, which were design led by us as commissioners of the app, not by the design team with Demagi, who were absolutely splendid. And what we managed to achieve was an application with high data capture, high data analysis that could work independently of power outages. And as you can see here, it works offline. It can be used in multiple languages. For those of us who don't speak Portuguese well, having the app in English was an absolute blessing. And then it produces these wonderful reports. So the team in Mozambique are now in an absolute state of knowledge about who is in which location, who has been exposed to tuberculosis, who needs to be put in isolation, who needs treatment initiation, who needs TB preventative therapy initiated, and also where disease clusters exist. So is it Pavilion 1? Is it Pavilion 2? So on and so forth. And it's meant that we've been able to raise our game massively around responding to TB and treating and ultimately eradicating it. So in terms of the scope, we're in 4 correctional facilities. We've got 66 staff trained. There's just over 8,000 patient records, soon to do another blitz. That'll go up to closer to 17,000 patient records, and all enabled by this wonderful application designed by Demagi. And as I said, I'm not paid for saying any of this. It's just a genuine reflection on great technology, great partnership, and great work. Kelly, how am I doing for time?
Well, we would like to move to questions in about maybe 2 or 3 minutes. So it looks like you're getting to the end of your slides, though. So I would run through the AI piece because I think it's interesting.
Sure, no worries at all. So very briefly, we've been able with partners to introduce artificial intelligence into disease detection in prisons in low resource countries. We do this by having the AI read a digital X-ray. As you can see from this slide, the patients absolutely love it, and we don't have to run after and find people. They come to us, they see this wonderful piece of kit, and they think we not only want to know what our diagnosis is, but we also want to have the experience of having an X-ray, which, hey, if it's the lever that brings people to the table, all well and good. We can work at volume, and we could do up to 600 X-rays per day, but because of staff burnout and because of, well, actually it's staff burnout, we limit it to 150. We don't want our accuracy to go down. So it's been a game changer for us in prisons in disease identification. The AI deployment, you can read the slide. I just want, the headline here is, it takes less than 1 minute to get a presumptive diagnosis, which we will then bacteriologically confirm for TB, which is staggering, which means isolation can happen immediately. The formative results, and remember, we've got all of these results from our Demagi Health Matters app. So we've got a data capture solution which absolutely tells us where we're at. What I'm very proud of, and the Eswatini team, if we can help in your prisons, you just give us a shout. The prevalence in country for TB is 361 per 100,000. The prevalence in prisons is 3,000 per 100,000. Now, the AI gives us a presumptive, we get the bacteriological confirmation, all of the results go into the Health Matters app, and we are able to get this data from that piece of technology, which makes our life better and which makes the patient's life much improved. So everybody is an absolute winner. We also extend out into the communities. We're able to capture data in the community and support families and their partners and their children to be as healthy as they can and link into services in that space. This was us in December of last year. And this is the wonderful Health Rewards team with all the partners in action in Mozambique. Kelly, thank you so much for giving us this opportunity to talk about the partnership work that we do. We couldn't do it without Surety, and we couldn't do it without Dimagi. Thank you very much.
Ivan, thank you so much. Really wonderful presentation as well. And I think one of my biggest takeaways from what you presented is, well, two things. One is that technology can really help provide solutions when individuals are hard to reach, especially in the Haiti context right now. Seeing the fact that we're still seeing active monitoring and support of cases, individuals that are affected by TB in these settings with the amazing unrest that's happening, and it's been heartbreaking to watch the news. And I check in with John often on the team in Haiti, and had a chance to visit one of the correctional facilities in Port-au-Prince, and so just understanding that situation that's on the ground, seeing that the technology can help you reach these individuals in a timely manner, I think is really wonderful to see. And then the second thing is, seeing how technology and real-time data access can help you address outbreaks very quickly, which I think, again, the speed with which you can screen, diagnose, and put a patient or a person on treatment, I think is really amazing. And watching you be able to pull this all together with Health Through Walls and with the Mozambican government, I think is fantastic to see. So thank you for sharing all of that. Well, we do have time for some Q&A. I was hoping to leave this open for everyone to enter their questions into our Q&A box. I do see a question here for Sajibu. Maybe we'll start with that's in the chat, and then hopefully that will kick off this session here. Sajibu, the question that came through to you is, how do you manage the issue around stigmatization to ensure that HIV status is known? It looks like you have a known case rate of 99%. So I think the question is around, how do you handle stigmatization to ensure that status is known in Eswatini?
Okay, thank you, Kelly. The healthcare workers, they do the health education to the clients, and with the assistance from our implementing partners, they've even hired some workers who know their status and who will come and talk to the client, and so that they can accept their status. And we have a number of organizations in Eswatini who do health education about their HIV status and the importance of disclosure. Thank you.
Thank you, Sajibu. I think this is a really interesting conversation around how do we empower patients with community health worker support. And stigmatization is very high with TB and HIV, I think, globally. And so the wonderful work that your teams are doing to help reduce that and help patients feel supported as they're going through this treatment while not bearing down on that stigma, I think it's great. So thank you for that, Sajibu. The next question that came in is, what is the percentage of patients who chose BOT and Eswatini over other options that are offered to them? So Sajibu, this is for you as well. Of those that are offered BOT, what is the percentage that choose that over the other options that are available?
From the MFAF pilots in 2020, the percentages were, our target was 50% on VOT, 50% on patient support. However, the percentage is around 40% and 40% down. Lately, we are around 30% who chose VOT versus a treatment supporter. Thank you.
Great, thank you, Sajibu. The next question is actually for you, Ivan. The question is, how have incarcerated communities responded to technology-based initiatives that Health Through Walls is rolling out? Were there any concerns raised from correctional staff or those who are incarcerated around technology, or any concerns around maybe privacy or data access or any of that? So maybe you could speak to that a little bit.
Sure, thanks very much for the question. What we found in both countries is that laying the foundation with the key stakeholders is important. So not only the people in prison, but their families, and with ministries of health and ministries of justice. Data protection and security are of massive interest, as you'd imagine, to people generally, and that's amplified in prison locations. And so we would go demonstrate the technology, demonstrate the limitations and the advantages of the technology, talk about where data storage occurs and things like that. We also, as you would have seen from one of my slides, identified within both locations peer educators in both the men's and the women's prisons. And in relation to those peer educators, did a bit of a communication piece around so I've just had somebody walk past me and it's distracted me. A communication piece around what the limits of the technology are, how the data will be used. And what we found, as you saw from one of my slides, is that actually this technology is new for decision makers and also for end users. And so there's a high degree of curiosity and interest, and also recognition, a positive recognition, that it's got a key space in developing and advancing healthcare and a healthcare response. So very little suspicion, very little interference running from us, very much more what we want to know as much as we can, but the doors are open, if that's not a contradiction for a prison.
No, I think the questions around data privacy come up for us often, obviously. Being a technology company, there's a big concern around who owns the data, where is that data sitting, who's looking at that data. And I think as a company, Damagi is really focused on ensuring that the data ownership remains with the partner or the country that we're working with, and that the data access is not on Damagi, right? We're stewards of the data, but we are not owners of the data. And so I think it's really important that we continue to take that messaging to our partners. And Sujaibu, I wanted to maybe put this to you because I think it's on the same vein that Ivan just mentioned around privacy and security. Eswatini, I think, is been on the forefront of choosing innovative technologies, for example, cloud-based solutions over trying to host data in the country. And I wanted to ask you that specific question around the conversations that were had in Eswatini around, being able to use cloud versus hosting the data in country, trying to understand the benefits of that decision-making process that happened, and understanding that the data is owned by Eswatini, but that it's actually hosted in the cloud. So I wanted to maybe see if you were willing to speak to that a little bit, and the decision-making process that happened in country when you were making decisions around privacy and security and data hosting.
Thank you, Kelly. Regarding of the hosting, we are using the cloud that is owned by Shoadhe. Now will use Damagi. It was mostly because it was piloted by MSF. I think it was like it was good at that time that with the use of the cloud, it was for protection rather than we are having a source it for using our server. Yeah, all I can say is that all we did, it was as MSF was our pioneers, and we found it good. And as MSF was using the cloud, the cloud, there was no leakage of the data. So basically, it was a privacy part. We didn't want our client complaining that they've seen their videos virally.
Absolutely. Sujaibu, I think you bring up a really important conversation when it comes to VOT and who is accessing the videos, and that the videos are, again, stewards. Damagi is a steward of the data, hosting the data, but the ownership of the data, the access of the data sits with the partner. And I think that's a message that we want to be out there, but also have worked with partners such as yourselves and Health Through Walls, who've been okay hosting in the cloud with the assurances around data privacy and security, and having a record of that privacy and security associated with the rollout. So thank you very much for sharing that. Well, we are over time. If there are any other questions, it looks like there's maybe one more question, and then we'll go ahead and end it out. The question is that if Health Through Walls can maintain focus on technology innovation amid such challenging circumstances, I think this was more of a comment, but he said, if Pelter Walls can maintain focus on technology and innovation amidst such challenging circumstances, we all can. And the question is maybe for both of you, what advice do you have for tech leaders to learn from both of your efforts?
I'm happy to jump in first, if that's okay. Two things spring to mind. One is the International Corrections and Prisons Association has a conference around technology in corrections. And I know corrections is not everyone's field, but there is a very good learning cohort and learning hub there that explores the use of technology as it applies to hard to reach populations or difficult to engage populations, or populations who otherwise don't necessarily get the full attention that they might want. And so I would suggest, if people are interested, and I think, as I've said, public health in places of detention fixes public health the whole world over. There are three forums through the ICPA, and if you want to contact me, more than happy to put you in touch. One is a dedicated tech forum that meets quarterly. One is an annual conference on technology, and the other is an annual conference. The next one's on humane treatment, which for any of us in the health space, whether it's prisons or not, is really important. So I would say that's one avenue to go through. The second is creating the time, and this is really hard, to have the horizon scanning conversations that link up need with a tech solution. And it's often by chance that we stumble over each other in the strangest of spots, and a random conversation that then light bulbs go on. So deliberately creating a dedicated space where you're like, right, I'm going to, even if it's 1 hour a week, I'm going to look at what the research says out there. I'm going to look at, philanthropic for-profit organizations like Dimagi and see what solution they've got for us. That is priceless. Thank you.
Thanks, Ivan, for sharing that. So, Jaibu, maybe to give you the last word here, do you have any advice for governments or tech leaders or NGOs as they're thinking about rolling out technology?
Yes, thank you, Kelly. I think VOT is the way to go, because the client is able to honor his or his treatment, and the healthcare worker is able to observe if the client is really taking, rather than relying on the treatment supporter. He said, she said. So I would say I was even talking to the AIDS program. They even wish to adopt for those clients who have got a high viral load, so that they can be monitored while they are taking the medication, so that for those clients to be suppressed. I think is the way to go. As the world is moving to technology, so even our clients, let's move the same direction on the technology. Thank you.
Thank you very much, Jaibu. And I think both of you have led with this message of empowerment, empowering people with data, empowering patients to sort of take control over their own treatment, and yet still supporting them as they go through this journey. And so we thank you both for being here today. This has been a wonderful webinar, and we very much appreciate you being willing to share your learnings with us. So thank you, everyone. We'll go ahead and close out the webinar. We appreciate you joining.